Hello and welcome to today's Florida HIE Services webinar. My name is Pamela King, and I welcome you all to today's webinar on our encounter notification service for hospitals. We do have a wonderful speaker that's going to be presenting to you today, and his name is Evan Carter. He's my colleague with the Florida HIE Services, and will be providing a lot of wonderful information about how encounter notification service can be used by hospital to help with population management and quality improvement. Before he gets started though, I do want to let you know that we will be having a question and answer period at the end of the presentation. But as you have questions, excuse me, as you have questions, there is a question pane if you want to just in the panel. So if you want to type in your questions, if something is spoken about and you don't want to forget, you can go ahead and type your questions. At the end, I will provide an opportunity for you to raise your hand, and we'll unmute you if you want to ask your question in person out loud. So we can do that. And without further ado, I'm going to go ahead and turn it over to Evan Carter.
Thank you very much, Pam, and thank you all for taking the time out of your morning to join us. We are extremely appreciative of your time and really thrilled to be chatting with you all about this opportunity today. As the title slide indicates, we know that ENS can be of tremendous benefit to hospitals for population health management and quality improvement, and this is priority number 1, 2, and 3 for us in 2018 is to get this service out in the hands of hospitals and really, give value back to, those of you who have been, excellent partners to the HIE for many, many years now. Next slide, please. And just by way of introduction, for those of you, I know there's a lot of folks on the line that I have had the pleasure of speaking to and working with in the past, but for those who I've not met, my name's Evan Carter. I'm with a company called Audacious Inquiry, and I'm the program director for our work on the Florida HIE. We are the prime vendor. I've been working on the Florida HIE since its inception in 2011, and we've been leading this ENS effort since we rolled the service out back in 2013. What we're going to talk about today, just real quick, I want to tell you an overview on how ENS works. I'm going to touch on some statistics about how we've proven the ROI, frankly, for how this can help population health. Show you some sample notifications, some sample endpoints, how the data looks. We'll talk about pricing. We'll talk about timelines and next steps. Next slide, please. So ENS at a high level, ENS stands for Encounter Notification Service, and it is as its name would indicate, it is predicated on routing encounter data from participating hospital to subscribing organizations, and those subscribing organizations can be anybody that has a treatment or care coordination relationship with a patient, a Floridian. So it can be ambulatory organizations, hospitals, ACOs, and health plans. I believe we have somewhere just north of 40 organizations subscribed to receive notifications today. This map on the right-hand side is indicative of our connectivity in Florida, which quite frankly is unparalleled, really nationwide. We've had, endless gratitude to those of you, on hospital that work with your hospital's interface teams, as you've made this possible. We have upwards of 220 connected hospitals in the state. 95% of the acute care hospital beds are connected. These are real-time feeds. These are not batched. We get an ADT, within seconds of its generation in a hospital EMR. We get inpatient and emergency data. And we get, the whole array of standard event types, admits, discharges, transfers, cancels, patient updates, things of that nature. Another big push, I said we want to get this data in the hands of hospitals this year. That's a major focus. The focus number 2 would be adding more to the breadth of the data sources that we have. In addition to those 220 connected hospitals, we want to add SNF data, post-acute data, ambulatory data. We know that's of great interest to our subscribers, and so we want to, really add those other data sources to truly close the loop on the care continuum and be able to alert on, acute to post-acute to ambulatory, all the way to home care, frankly. So that's another aspect that we're pressing on right now. Next slide, please. So traditionally speaking, the first way in which we envision ENS being of benefit to hospitals is really having a traditional, so to speak, panel-based subscription of frankly, generally speaking, your at-risk population. If you've got an affiliated ambulatory network, if you've got an ACO, or you have any sort of bundled payments going on, those are obviously the folks that you want to know about, that you want to minimize their their expenditure, quite frankly, and their hospital encounters. And in that vein, that is, we've had the privilege of working with folks in that space for some time now, and some of our partners have been able to do some in-depth ROI studying, which is tremendously valuable. And they've articulated those findings back to us, and it's been tremendously promising and exciting. In working in that space, in that population health use case that I mentioned, the first benefit that folks have seen by using ENS is simply that they get better data. One participating ACO had a direct ADT feed from the only hospital system in the service area. And that they presumed this is this community's hospital. This is where everybody's going to go. If we just get a direct ADT feed, that'll cover us. When they held that ADT feed up to the claims they were receiving for their ACO population's member ER utilization, they realized there was a significant gap. And as such, they said, okay, well, we need to subscribe to ENS to see if it can give us more than what we're getting from our community hospital partner. And by virtue of using ENS in that situation, they were able to capture a 35% increase in their total patient ER utilization by way of ENS. And that tells me 2 things about ENS. Number one, a lot of healthcare is local, very local, but your patient population is always going to travel a little bit further than you may estimate for any one of a number of reasons. And as such, it's always, if you plug into statewide connectivity, it's going to be beneficial no matter how closed you think a given community may be. And then the second thing that tells me is that, frankly, the intricacy of our matching process, how we determine, the contents of an ADT applies to your affiliated patient is extremely, mature and very advanced, and I think that's allowing us to deliver a little more than somebody may even see through a direct ADT feed as well, by way of variances on names and things of that nature. So better data. In addition, one other thing I'll add in terms of better data is we're also getting up-to-date phone numbers and addresses that are conveyed to the treating hospital at the time of the encounter. So if you've got an ambulatory population that you're having trouble getting a hold of because you've got an old phone number, that's something that customers have articulated as being a really big benefit of ENS as well. Next slide, please. So subsequent to just getting more data and getting better data, the obvious next step there is that you're able to reach out to more folks post-discharge and get people into an provider's office more efficiently for follow-up care. One ACO that is a subscriber to ENS in Florida had over 73,000 transitional care management eligible discharges during a study period, and they were able, and for any of you that aren't aware with the transitional care management parameters, you've got to get those folks into an office either within 7 days or 14 days after their hospital discharge in order to take advantage of those TCM codes. And, you know, obviously that's pretty tough to do unless you're finding out in real time when those discharges are occurring. And that ACO was able to get, use ENS to get 69% of those 73,000 discharges into the office for a follow-up visit within that time frame. And so that alone, just being able to take advantage of those transitional care management CPT codes allows you to, is a tremendous revenue opportunity for your affiliated ambulatory network. If you own physician practices, that can be a substantial opportunity just in and of itself, being able to bill at a slightly higher rate for those follow-up visits and get a higher volume of them. But obviously also, we all know, if you can get somebody into the office soon after a hospital discharge, it drastically reduces the likelihood of an avoidable readmission shortly thereafter. And one of our participating ACOs actually saw a 40% reduction in readmissions per quarter during the first year of subscribing to ENS compared to the prior year of not using ENS. So that is, again, for your at-risk patient populations, that is a tremendous opportunity for cost savings. Next slide, please. Last but not least, all this leads to saving money. Another one of these participating ACOs, and this was a small one, this was only a panel of about 10,000 patients, and they attributed a total annual savings of $284,000 to their ENS subscription via avoidable readmissions. And like I said, that's 10,000 patients. If some of you all are affiliated with much larger ACOs or have a much larger at-risk population, those numbers scale proportionately. So it's a huge opportunity. Another ACO, again, we talk about, spending, you get money back through TCM, but you can also save in terms of what you do not spend. And another large ACO saw their 90-day total spend post-discharge decrease by $2,000 per instance when using ENS to capture TCM codes. So, I mean, that's tremendous savings, and we were thrilled to see folks being able to really benefit so greatly by using ENS. So I think these are all, highly relevant, highly applicable, and enticing statistics as to, what the return on investment could be by participating in ENS. Next slide, please. So that is, so again, just now that I've kind of gone over, we've touched on how ENS works, we've touched on the benefit, but just to make sure we're explicitly clear on how the service works in that population health use case that I just described, a subscriber such as yourselves would submit a list of patients to ENS, including first name, last name, date of birth, gender, address, other demographic info. And that just generally comes to us via a CSV file. Whatever you can export from your EMR, generally speaking. And then, of course, we're receiving the ADTs from our 220 participating data sources in real time. And we match, like I said, we match those inbound hospital ADTs to the subscriber patient list based on those demographics provided. And we've got a really best of breed master patient index that uses a probabilistic matching algorithm to compare those and make a match. The matched ADTs are routed to the appropriate subscriber. By default, unmatched ADTs are discarded. And subscribers can determine, there's total configurability here. When you receive the notifications, what frequency, what format, where we deliver them, HL7, CSV, do we send them to you via direct messaging? Do we put it to an SFTP site? Really, we have a web-based user interface we can give you access to. Possibilities are really endless in terms of how you want us to get this data to you. Next slide, please. So everything I just described is kind of how we got off the ground with the service, and we have a recent policy development that has tremendous implications and really broadens the scope of what we can do tremendously is around the topic of ADT aggregation. As I mentioned, it used to be that unmatched ADTs were discarded it used to be that we really only, current state, we're only aggregating panel data, the data that a subscriber gives us via that CSV file of the patients they want to subscribe to. But now there is an option to allow for your data to be aggregated, that ADT data from a data source to be aggregated in the HIE. And again, that's optional. Folks just need to sign an addendum to the agreement they've already signed, and we can start doing that. And the reason we want to do that aggregation, the reason we believe it would be beneficial, is 4 of them. We think we can use it to create and maintain a panel on behalf of a participant. If you, for example, so we had that use case that I just described where everybody's sending in a CSV file of their ambulatory population. Well, what if you want to subscribe not to your ambulatory population, but you want to subscribe to your hospital discharges to track readmissions in a 60-day window? Excuse me. Well, since we're already getting all your discharge ADTs, we can do that for you. We can automatically subscribe you to your discharges. If you allow us to retain that data, we can automatically subscribe you to your hospital discharges and track them for a 60-day window and tell you in real time if they show up for a potential readmit at another facility that's outside of your network. So we can automatically build those panels and follow your discharges for you, as soon as they leave the door. We can also include or derive additional encounter data in alert messages. And really what's powerful here is that if we're aggregating ADT data, we can compile a prior encounter history on any given patient. And if, me, Evan Carter, I show up in your emergency department and I have 3 aggregated encounters that are already sitting in the Florida HIE, and I show up to your ED, you could send us that AO4 registration ADT. We could query our ADT repository and then tell you, this patient that just showed up in your ED, they've had 4 prior encounters, all for the same thing, all within the past month. This is a high utilizer, act accordingly, high risk, what have you. Know about my prior conditions, know about other folks subscribe to me, things of that nature. So that is really obviously powerful data we can, especially in the hands of an emergency department, that we can give folks if folks are simply interested in signing this aggregation addendum. More kind of behind the scenes, we can also use that aggregated data to improve matching through transitive linkage. I won't get into that, but it's a pretty technical concept. And then to also facilitate location of patient records, because if we're aggregating ADTs, we can say we know where a patient's been, and we can do more targeted searches for patient records down the road. Next slide, please. So again, I touched on that hospital auto subscription as being the first big thing we think we can do if folks were to want their data aggregated, if this were an appetizing use case. So again, through that hospital auto subscription use case, instead of submitting a panel of ambulatory or ACO patients, hospitals such as yourselves can allow the HIE to automatically build a panel based on your discharges. We would subscribe you to that hospital to all patients contained in AO3 discharge messages for a certain period of time. Generally speaking, you got a 60-day readmit window that you're at risk for in most bundled payment models and things of that nature. So that's what we'd hang on to. But that again, that's configurable too. But then we would automatically remove those patients from the panel when those initial discharges have aged out. If I leave your hospital and create a discharge, I am added to your panel for 60 days. If no further encounters happen in that 60-day window, on the 61st day, ENS will go through and automatically remove me from your panel. And obviously, the idea here, the opportunities that this enables hospitals to easily track adverse events and readmissions after hospitalizations occur in network. So it's tremendously beneficial in that regard. Next slide, please. As I said, this is kind of the other big use case that we can enable, or enhancement to an existing use case that we can enable if folks are willing to allow for data to be aggregated. And that's, again, getting prior encounter histories embedded within all standard notifications, but I think that's most noteworthy in the context of an emergency department when somebody's showing up with and you don't have time to aggregate your own clinical encounter history and call hospitals and whatnot. So the way that would simply work is patients registered in the emergency department, we receive the registration ADT, and then we query the aggregated ADTs for any other encounters pertaining to that person that we've been able to aggregate. And then we deliver notification containing encounter history directly into the ED system or interfaces. And that is of great importance, is again, especially in the ED where things are hectic, where doctors are the busiest, especially not a time to ask somebody to go log into a direct messaging inbox or go log into a portal or go pull something down from an SFTP site. And we very much pride ourselves in our ability to not force folks to use some sort of a Florida HIE branded portal. We have those available, but we want to put the data in the system that's already most closely embedded into somebody's workflow, whether that's an EMR, whether that's a bed board, whatever the case may be. We can embed our data into that system so that it's already in the thing that everybody is already looking at. So I've got a human readable sample here on the right-hand side, but I want you to also envision the same data being available in an EMR in the user interface that you're already most familiar with. And so, again, in this scenario where somebody just presented in the emergency department, this top right-hand portion where you have patient information and facility information, that's going to be the patients that just showed up. That's going to be your facility. But then we have prior clinical visits down below, and you can see, in this instance, Lower Bucks Hospital, they had an inpatient encounter in November of 17, and you've got the diagnosis codes, descriptions, HCC groups, so we can do all of that. And again, you immediately know you're dealing with a diabetic patient, and that alone can, save you thousands of dollars in that one given encounter. So it's tremendously powerful. And as you can, we are, as I said, we're extremely flexible, and we want to pull as much data as we can from as many data sources as possible. And we are really working towards being able to make API calls to any other repository of valuable data above and beyond and in addition to hospital encounters that we can possibly get our hands on that you all are interested in. One very obvious example is prescription drug monitoring program data. And there is, in Florida, a PDMP repository containing everybody's Schedule 2 through 5 narcotic dispensation records. And we have been actively watching some legislation in Florida that we hope will ultimately give us the ability to make an API call of that database such that this notification you're seeing right here, right in between the patient information and the prior clinical visit, we can put a section in there that says PDMP data, and you can find out whether this person has an opioid history or not, which I don't need to tell anybody how important that is from a public health standpoint. So again, it's kind of nobody from the HIE standpoint can get their hands on that data right now, but it's technically feasible. We're actively working with the right folks in the Department of Health, and we are very optimistic that we'll be able to do that in the future. And so again, what's the summary, the thesis statement, the last bullet on the bottom left is that your ED facilities now have insight into prior conditions, frequent utilizations, and other risk indicators immediately at the point of care that you never would have had access to otherwise. And hopefully save yourselves, a lot of trouble and lead to much better patient outcomes in the ED. Next slide, please. So getting back to the kind of the more traditional notifications and what is in a standard notification, just to kind of take it back to basics a little bit. We have, what comes in an alert is the, obviously the ADT, the encounter details from the hospital, where it occurred. We get everything from, like I said, up-to-date demographic and contact information for the patient, the facility, the patient class, whether it's inpatient or emergency. We get primary complaints, we get discharge diagnoses, we get discharge dispositions to some degree, we get attending physicians, step indicators. It's a very rich data set. And then we also deliver to folks custom fields that they provide to us in their panel. If you are submitting, again, a panel of your ambulatory patients, your ACO population, you can include in that panel not just their name and demographics, but you can also say, this is their PCP, this is their PCP's phone number, this is the physical address, this is the the specific care coordination program they're in, if they're diabetic or HIV or anything that would. And all we do is use that data to feed it back to you in the context of your notification, so that when you receive the notification, you immediately know, who is this applicable to, what type of outreach do I need to initiate based on what, where they exist within our care coordination programs. So folks find that extremely helpful. We have total flexibility there. Anything you can provide to us, we can give you back in your notifications. Again, as I mentioned, if we were to aggregate, I'm sorry, go back, yeah. If we were to be, folks were to opt into aggregation, if we were to pursue, as we pursue broader integration opportunities, things like utilization history, risk scores, chronic diseases, PDP data, care team information, we can put all of that into an encounter notification and bring you an incredibly robust set of data on a given patient. Next slide, please. What we gave you on the last slide was, you saw effectively a human readable notification on the left-hand side, and the data sources, some of the data elements on the other side. If you were to receive a notification via direct messaging, this is how generally those look. They just come as an attachment. You can see a CSV file in the attachment of that direct message. And that's generally how we deliver them via direct messaging. We will just send you a structured file in the attachment of a direct message that presumably your hospital EMRs or ambulatory EMRs, whatever the case may be, can open those up automatically, and especially if we send it to a particular provider's direct messaging address, and then populate that within the EMR. Next slide, please. Super simple screenshots just to illustrate the fact that we can deliver via a number of mechanisms. We can also put the notifications to an SFTP site. We can host an SFTP site. You can host the SFTP site. Doesn't matter to us. But again, you see we can post HL7 files, CSV files, real-time, batch, total flexibility there. Next slide. I mentioned previously we also have a web-based user interface. I said we don't, we're not pushing folks to the thing that's branded with our logos and whatnot, but it is there if it's the best option for what a given subscriber's, infrastructure and resources currently are. And this was, we effectively built this. I won't get into too much detail, but we really built this interactive web-based user interface called Prompts, based on feedback from folks who have been getting notifications via CSV and HL7, and they said, this is great, but I'd love to see, I'd love to be able to interact with the data a little more. I'd love to be able to filter the data a little more heavily. I'd love to be able to, mark my progress in the course of care coordination, post-discharge care coordination. All of these things you can do. You can, mark folks as being in progress or completed as your doctor's offices facilitate that post-discharge follow-up care. You can see event histories again on the bottom of this screenshot. You can see that we provide event histories as well in the context of this. And again, you can filter as well. A lot of folks have monthly reporting requirements, and they need to know, I need to see all of the encounters in the past 30 days as COPD or were heart failure, whatever the case may be, and you can filter based on anything in the ADT. You can filter and run reports through prompts. So again, just another option, very user-friendly way that folks can receive their notifications. Next page. This is a very technical slide that I am not fully equipped to get into all the details of, but hopefully those of you that know this stuff much better than I do from a technical side of things, the point of this slide is to further hammer home just how flexible we are in terms of how we can integrate into your existing systems and your existing workflows. We have extensive flexibility with the payload. You CSV, JSON, HL7, CCDs, HTML, you name it. We can package the notification up and get it to you that way. And if you have a specific transport method that you prefer, we can get it to you via that transport mechanism one way or the other. So again, very much total flexibility. If you're wed to a payload, if you're wed to a transport mechanism, we can make it work. So little footnotes there. ENS natively connects via web services to select HISPs, and we've integrated with Doc Halo for secure texting as well. That's not something we've done in Florida. We've done it in other states, so that's more so to illustrate there's the proof of concepts there. That's something we can do as well if there's strong interest there. Next slide, please. So pricing. What's the pricing? We have gone to great lengths to give our data sources, hospitals such as yourselves, as you're powering the service with your data. We want to do this. I mean, this is as cost effectively as we possibly can make it. This is a significant discount off the the broader market rate for subscriptions, and that pricing is simply 22 cents per patient per year for the first 50,000 patients, 11 cents per patient per year for any and all patients above that 50,000 threshold, and there's a 7,500 minimum annual subscription fee. So you see, bigger, if you just want to subscribe to your highest high-risk utilizers and it's just, 8,000 folks, that's $7,500 a year. If you're a massive system and you want to track and you got, an ACO population or an own physician practice population that's in the, in the 200,000 range, $27,500 a year. That's, if you go back to the slides about, quantifiable ROI, you'll see there's a big delta between the price and what folks have very, clearly proven to save and make via utilization of ENS. And we're really, really eager to, ensure that other folks see those same benefits. Again, I cannot possibly stress enough. I know I sound like a broke record. You all have been wonderful partners to us over the years. We want to get this to you as quickly, as easily, in the most cost-effective way possible, so that you can benefit from this data and these opportunities. So that's the impetus behind this pricing. Next slide, please. So this is a proposed onboarding timeline, and really, the takeaway here is to notice that it's 4 weeks. This is when folks ask for a project plan, this is what I give them. I don't have a Gantt chart with 100 rows that spans 4 months or anything like that. It's this easy. You all have already signed our participation agreement as a subscriber. So there's legal organizational precedent. It's always a good thing. You just need to sign a separate signature line as a data recipient. Then after that, we're working on transport mechanisms and endpoints. Again, do you want to host? Do we need to get you SFTP credentials, or do you need to get us SFTP credentials? Do you need to get us a list of direct addresses, whatever the case may be? But very straightforward. And then shortly thereafter, you generate that panel, export from your EMR, or we're doing that auto subscription where we're just holding on to your discharge ADTs and tracking your readmits. Either way, that all can occur within a week. Really, if folks are engaged and everything's following the way it should, that can happen within a week. And then week 3, we're live. We're delivering notifications. And then, we're big proponents of incrementalism. So, we think about, go speed to go live with the most basic way in which we can get you the notifications. And then once you're getting those notifications, you're seeing the data, you're getting accustomed to using the data, let's pursue deeper integration. Let's figure out how we can get the notification directly in the hospital emergency department bed board, like I said, or within your ambulatory doctors' EMRs, or whatever the case may be. Let's figure out how to make it perfect from a workflow optimization standpoint once we've got the data flowing to a central location that you all can start to utilize. Don't let perfect be the enemy of progress, I guess is a cliche way to put it. Next slide, please. I think that's it. Yeah. So you all have please make note of our contact information. Please visit the website, poke around. We've got some more supplemental information on ENS there. You've got our help desk inbox that's managed by a handful of us that will reach out to you very quickly if you have questions you don't want to ask here today or anything along those lines. Feel free to shoot us a note anytime. And that phone number is my cell phone. Please call me anytime. Again, I just I want to help out as much as we possibly can. With that, I'll turn it back over to Pam, and yeah, we'll see if we have any questions.
Okay, and so now it's your turn to ask questions of Evan or myself about the service. You can raise your hand in the webinar panel just by clicking on the box if you have questions. I do see that Susan Moore has a question, so I'm going to unmute you, Susan.
Yeah, actually I had two questions. So the first was, this is an awesome presentation that I'd like to show my people here to try to get this moving. Will this be available after the call?
Yes, you will get an email actually of the recording of this presentation, so you'll automatically get that sent to you.
Okay, and then the second thing, you mentioned CCDs, so you could send me event notifications via direct messaging using a CCD format. Is that what I was understanding?
Yes, we know there are some EMR vendors who are very much prefer that if we're sending structured data as an attachment to a direct message that they get a CCD as opposed to an ADT or an HL7 file or a CSV, and so we can do that. We've done it. We've done it in other geographies, other states in which we work. We are pushing CCD messages to Epic direct inboxes, and it contains the encounter data just as a very small scaled down portion of the CCD. So yeah, that's exactly what I meant, and it's being done elsewhere.
Okay, sure, because that actually would be something that I could consume fairly quickly because I already have the structure in place, and we just recently turned on our integration of outside encounters to our chart review. So this would be ideal, I think. So we probably need to talk soon.
Excellent, excellent. Yeah, we're having those conversations with other folks right now as well. Okay, I would say in full transparency, probably tack on another week to that timeline I proposed if we're doing that transport mechanism, but still, 5 weeks. But okay. We can do it. We'd love to do it for you.
Okay, great. Thank you.
All right, I'm going to mute you back, Susan. I'm going to follow that up, though, with we had another question that was typed in about the formats. So can subscribers get the alerts in multiple formats instead of just
Yeah, that's a great question. I should totally be clarifying that. That pricing model that I proposed, that is based on the amount of people you are subscribed to and nothing else. If you're subscribed to 50,000 people and you want the notification, it's the same price to get 1 endpoint versus 3 endpoints. You can get structured HL7 sent via direct messaging, and you can get batch CSV files sent twice daily to an SFTP site. Same price. Total configurability, optionality. You can, we have many folks who are getting notifications today via, 2 or 3 mechanisms, and we can absolutely accommodate that, and it's no additional cost.
So they can get real-time and batched data as well, too, right? Another question is, can we use ENS to get encounter data to clinics that we own or refer to?
You most certainly can. We are piloting that with a hospital now. We're doing it with a couple of health plans. I don't want to get too much into the history behind this, but Florida's a big state, a lot of ambulatory docs. So very early on in our engagement in Florida, we try to think of what is the most efficient way to get this data in the hands of these PCPs without needing the PCP to have their own subscription and you know, go through that 4-week onboarding process themselves. And so what we thought was, again, as I mentioned when I talked about the custom fields in the panel, you can put the PCP's name in there, you can put the PCP's direct address in there. And we have a number of subscribers who have told us, large subscribers, health plans, hospitals, they say, here's our panel. I want to receive notifications on this entire panel. I want, you know, these 5,000 people I need a copy to go to this practice. These 2,000, I need a copy to go to this practice. And if you can identify them, if you can differentiate them by, again, who their PCP is or who their practice is via a custom field in our panel, we will happily send forward a copy of those notifications to the appropriate PCP. So you don't have to get the notifications and figure out who the PCP is and then forward them on to them on a daily basis so they can do the post-discharge care coordination. We'll put it right in the hands of the PCPs as well. And again, we can do that via web interface, SFTP, direct messaging, no additional cost.
Okay. We have another question. It's a hospital that's already a data source, and they want to know kind of what is that process to transition into being a subscriber, to participate as a subscriber, if you'll go back over that.
Yeah, it's you know, you sign the same, you know, the participation agreement has a signature line for data sources. And if you are a data source, you've already signed that. If you'd like to see a copy of that, I can send it to you. So shoot us an email at that FLHIE help desk, and I'll show you your active agreement as a data source. You simply sign that same agreement as a data subscriber as well. And once you do that, again, it's a matter of which use case you want to pursue. If you want to manually submit a panel. That is, again, like a CSV export from your EMR to track ambulatory or ACO patients, and it's just a matter of how quickly can you get us a panel that's in the very simple format that, you know, template that we need, which again, folks don't have a problem with, especially, you know, organizations of a hospital size. It's not a difficult format or template that we require. Again, that should be doable in a week. Whereas conversely, if you want to subscribe, you know, if you want to pursue that auto subscription wherein we're subscribing you to your discharge, your hospital discharges to monitor for readmissions, you're already giving us that data. So there's no further action that needs to be taken. So we can start building you those panels right away. It doesn't even take that 1 week. And then again, subsequent to that, it's, you know, how long does it take to set up you know, the endpoint? If you want us to send this information to an SFTP site, we can get you SFTP credentials to our site within a day. Presumably, it wouldn't take too long for you to get credentials to your site to us as well. So again, a week is being very generous there. And then we turn it on and the data's flowing. It's as simple as that.
And I have a follow-up question. How does the patient consent work?
The patient consent works because hospitals are filtering notifications for which they don't have consent, and you know, we go by the, you know, same opt-in universal authorization model that is already in place within every hospital's existing workflow. I mean, we are not moving data we're not moving different data or to different people that exist in the paper-based workflow today. We're just doing it faster. So the existing, you know, opt-in authorization model that's in place throughout the state of Florida to cover paper-based, you know, data transactions is the same that's applicable for us.
Right. So basically, they just need to get patient consent to allow for receiving and sending information, just as they normally do, as they do now. Right. It wouldn't be an extra consent. Okay, I'm looking to see if we have any other questions or if somebody has their hand raised. I am not seeing any. I'm going to give you just a few seconds to see if you want to type anything else in. Other than that, I can't remember if we asked this one or not, but I think we did, about getting data to clinics that are owned by facilities. Did we touch on that one?
Yes.
Can hospitals use ENS to get encounter data to clinics?
Yes,
Yeah.
Via
Okay.
direct messaging, SFTP, we can route notifications specifically to their providers if they can be.
Okay.
Out.
Okay, then I think we have answered all the questions that we have for today. I want to thank you again, Evan, for presenting, and thank all of you for your time. If you have questions that you just didn't want to ask or come to you after the webinar is over, please email them to the email address on your screen, and we will get a response to you, or you can just respond to the email from the webinar as well, and we'll get an answer to you either way. So have a wonderful day, everybody, and hopefully we've answered some questions for you. If you have additional questions, we are here to answer them.
Continue to hold.